today, all three pregnant patients in first, second, and third trimester, 3 cases that we have had in the ward in the past 2 weeks. So first case, Mrs. M, she's a 32-year-old multigravida who's at 8 weeks of gestation with nil antenatal risk factors, mostly just mild anemia, came with complaints of loose stools for 10 days, over semi-solid to watery inconsistency and vomiting for 3 days, along with some mild abdominal cramps, but no blood or mucus in stools. She also gave history of hotel food consumption, and she also had 2 low-grade fever spikes. Second case is a 26-year-old multigravida at 30 plus 6 weeks in her third trimester with no antenatal risk factors. She's a dietitian who is from Vellore, came with complaints of 5 to 6 episodes of loose stool with high-grade fever. She also had food intake, but she did not give any history of food intake from elsewhere. Small volume watery stools, no blood or mucus. She also had some mild lower abdominal pain along with lethargy. This was acute onset with 1 episode of high-grade fever. The third case is a primigravida at 23 years, 20 plus 1 week of gestation, was a homemaker from Nellore in Andhra Pradesh, came with complaints of 15 to 16 episodes of loose stools along with severe tiredness and lethargy. She had food intake from elsewhere at a marriage function, large volume watery stools, but no blood or mucus. She also had decreased urine output with severe fatigue and lethargy. It was also acute in onset and no fever. So before moving on to the further part of the presentation, I just want you to take a look at how we assess dehydration, which is adapted from WHO. So as soon as the patient comes in, we look at these parameters. One is the mental status, the radial pulse. We look at how the eyes are, how the skin turgor is, and how the thirst is. Accordingly, we can quickly assess them and classify into no hydration, some no dehydration, some dehydration, or severe dehydration. So on examination, our first patient, she had a temperature of 100 °F with a pulse rate of 98. BP was 160, but she had some dehydration according to what we saw previously on examination, on the initial examination. Other than that, there was severe dehydration, but the patient was conscious and oriented with tachycardia, hypotension, and she also had reduced urine output. So the clinical picture of all 3 cases, acute gastroenteritis with different levels of dehydration, plus minus fever. So the differentials that we were thinking about, depending on the symptoms, as we know, we would first classify them into probable large bowel versus small bowel. Large bowel, the differences we took into consideration. The first patient who came in her first trimester, she gave around 10 to 14 days history of loose stools, but not large volume, small to moderate volume. And she also had history of consumption of food from elsewhere. So we were thinking probably large bowel only. And in the second case, also similar symptoms. So maybe large bowel, but in the last case, large volume watery diarrhea with a lot of severe fatigue, maybe small bowel. Can also be viral, bacterial, or protozoal. These were the most common differentials that we take into consideration. So in the first case, Mrs. M, she also had some low-grade fever. Her counts were mildly elevated at 13,500. Electrolytes were normal, but in stool routine parasites, we saw that giardial cysts were present. In the second case, in her stool culture, we found out that she had non-typhoidal salmonella. As you can see, she initially had some dyslipidemia, which we corrected with IV fluid supplementation and vitamin K and potassium correction. In the third case, the patient who had severe lethargy and large volume watery stools with decreased urine output, as you can see, her creat was initially high at 1.2. She also had low potassium to start off with, and stool culture grew Vibrio cholerae. So how did we manage these 3 patients? So the basic principle that we followed were the same for all 3 patients. First is to assess them and to see if they were stable at presentation. If they were not, we resuscitated with fluids. Then we monitored the electrolytes. And the first and foremost thing when any pregnant patient comes is not to waste time on finding the etiology. Rather than just going on giving fluids and ORS, there should be an attempt to find out what the etiology is, so that will help in preventing further complications for both the mother as well as for the fetus, and treat the cause accordingly. So in the first case, this patient was in first trimester whose stool routine parasite showed giardiasis. So as of now, according to ACOG and RCOG, there is no consistent recommendation per se in first trimester. But what we do follow is that we can give them paramomycin. Paramomycin is the only acceptable drug as of now, which can be given in the first trimester. But the problem why we give it is because it has got poor systemic absorption, and the dosage that we give is 10 mg per kg thrice daily. We can give for 5 to 10 days according to the symptoms. But the only the cons is it's not easily available, and for 1 gram of the medication, the cost ranges from 3,000 to 3,500 rupees. It is not available in CMC as well. So, but if the patient is untreated, having said that, if the patient's nutrition is adequate, if the symptomatology is okay, if she's able to tolerate orally, if she's stable, there is no immediate need to treat the patient with paramomycin. We can wait. But one thing that I want to highlight is please do not treat the patient with tinidazole or metronidazole in first trimester. We can always reassess in the second trimester, and then if need be, we can treat at that point. Usually what we give is metronidazole. In the second case, which is non-typhoidal salmonella, all cases, if first thing is hydration, if the patient has fever, that is another entity. In our patient, she had non-typhoidal salmonella. It was an uncomplicated case. Even though she was an IP, she was stable. So how to go about treating this is, if it's an uncomplicated case, what we do in pregnancy is to treat with 7 days of azithromycin. 1 gram OD, 7 days is the first line of antibiotic. Now, let's say this patient was more sick. As an IP patient, we can start off with IV ceftriaxone, which can be given as 2 gram once daily or as 2 times daily. And then you can change to azithromycin to complete at least a total of 7 days. And in case of resistant strains, we can give meropenem even in in pregnant mothers. And then you can change to azithromycin at the time of discharge. Additional measures, if the patient is really sick, needing ICU care with decreased level of consciousness, you can give Dexa as a loading dose and then treat the shock and stabilize the patient. Vibrio, the main highlight is fluid resuscitation. Unless you resuscitate the patient, especially if the patient is pregnant, we cannot save the mother or the fetus. So as soon as the patient walks in, depending on, it is actually MSF guidelines say that even without going on to further management, you can, if she's in severe shock or if she's very dehydrated, you can start off with 2 large bore IV lines and start the fluid resuscitation before going into further evaluation of anything. So here, how we can protect the fetus also, especially in the 3rd trimester, is to make sure that the mother does not have shock. The antibiotic therapy that we give is 1 gram start dose of azithromycin. The goal of antibiotics is basically to shorten the duration of diarrhea, and thus we can reduce the duration of vibrio exclusion in stool. So I gave a brief overview of how we managed our patients. So all of them were actually stable enough to be in ward. None of them needed ICU care. So in the first patient, we did not have paramomycin. So we have called her back in her 2nd trimester. She will come and review with us. And if need be, we will treat her. In the second patient with salmonella, it was an uncomplicated type. So we gave her 1 gram azithro OD for 7 days. We corrected her dyselectrolemia. And she was also in 3rd trimester. So whenever there's a patient who's come in with gastroenteritis in 3rd trimester, other than just monitoring the mother, we have to make sure that fetal monitoring is also being done. One thing that I would advise is whenever they're coming, make sure that they usually lie in left lateral position, and strict direct fetal movement count is one thing you have to re-emphasize to the staff as well as the patient. And in between, fetal auscultation. And if required, a scan can be done bedside to reassure the mother by showing the cardiac activity. In the 3rd case, after adequate fluid resuscitation, the AKI had resolved in itself. We gave her a stat dose of azithromycin and ORS as and when required. And we also notified the HICC team because it is imperative that we notify the local PHC, Bar Panchayat, so that they can trace the source and treat the nearby locality also. So the most common complication, obstetric complications due to cholera is IUD. Usually I'm talking about third trimester. IUD, that is also because of maternal shock. Another thing is spontaneous abortion in first trimester, or if this patient is in sepsis or is in shock and goes into labor, they are known to have PPH. More chances of PPH. So some 2 or 3 studies that I'm bringing in. This study of usage of paromomycin came in 1981 actually. After that, there have not really been any other consensus or much other studies. So even now what we use is paromomycin because it's less toxic and is safer in first trimester. There's this case study about the salmonella, actually a case analysis which was done from a period of 1966 to 2018, which was talking about non-typhoidal salmonella. So the total prevalence is only about 0.2 to 1.8%. And 90% of these mothers had fetal sepsis later on after postnatally, and 60% had spontaneous abortion, and 80% had fatal outcome of fetus. Is probably an intrapartum IUD or postnatal IUD, which have, immediate postpartum death because of sepsis. So why I'm bringing this up is it's important for early diagnosis of etiology. That is why stool culture early on so that we know what the etiology is. Regarding cholera in pregnancy, the study was done in Haiti in 2010 to 11.
Can we just speed up maybe?
Sure. And it was a cohort study which basically emphasizes the fact that severity of dehydration is the most important risk factor that can cause complication in pregnancy. So the key points: assessment of dehydration, fluid resuscitation, and especially the drug of choice in pregnancy changes according to each trimester. And other than just the patient, we have one more passenger with the mother. So fetal monitoring as and when required should be done so that we can prevent complications. Thank you. And I want to thank Dr. Audrey sir also for helping me with this presentation.
Thanks, Dr. Anne. So I think the moral story is not to eat outside. That's difficult. That's a difficult part, I think. Any comments? So would you suggest just giving azithro to all pregnant patients who come dehydrated, moderately to severely dehydrated as a stat dose? Is that a recommendation? Like here, I think in the
currently
we don't do that.
Only thing is normally for a non-pregnant patient we give doxycycline.
Yes, correct.
But in pregnancy, doxycycline is contraindicated. So the drug of alternative drug is azithromycin for fetal cholera, but it's not that well studied for efficacy compared to doxycycline. The other advantage with azithromycin is it also takes care of
salmonella, exactly.
In pregnancy, we've not had, not for the mother, but our babies don't do well whenever the mother has salmonella. So as she showed, almost 90% of them had mortality, even with our entry fevers with salmonella. The babies don't do well because the salmonella has this tendency to just go into the placental macrophages and cause a bad infection. So that is the issue with salmonella in pregnancy. And with the giardiasis, we can't use needle dose.
We can't do maternal.
And we tried searching for paromomycin, but we just couldn't.
So all the nitroimidazoles are contraindicated, huh?
First trimester.